All right, wonderful. Welcome everyone to a joint webinar with myself and Dr. Stacy Barber. We are going to be focusing on neurological injuries and taking a sensory-based approach on how we can improve movement, balance, prevent falls, and support overall quality of life for these individuals, or if you are a clinician, for these patients or clients that you may be working with. We're going to give a really great background on some of the thought process behind it, some of the primary concerns, and then going into some of the programming of how both myself and Dr. Stacy look at neurological conditions. Before we jump into that, though, we are going to give a brief introduction to ourselves, and I will let Stacy start.
Okay, so I am Dr. Stacy Barber. I am owner of the Physio, which is here in Phoenix, Arizona. I'm a physical therapist, but I also am a strength conditioning coach and have a background in gymnastics and Olympic weightlifting. And many of you guys probably know at this point that my husband had a stroke about a year ago. So I've been really diving deep into the neuro rehab world and kind of helping him along the way. And obviously, the things that we're going to be talking about today and the things I'm going to be sharing are a lot of like what I've been doing with him that's been working, and then just things that we have been trying recently too, based on research and evidence and all of that stuff. So, like I said, physical therapist, and I now have a new passion for neuro rehab, but I am trained as a sports and orthopedic physical therapist.
Love it. So my name is Dr. Splickle, Dr. Emily. I am a functional podiatrist and formerly trained as a surgeon, traditionally trained podiatry, but then have shifted my focus to be on more the sensory side of human movement. I'm
I'll
also a
tell you
human
about
movement
it in a little
specialist
bit.
and very passionate about the nervous system and how sensory stimulation shapes body perception, and then how we navigate this physical canister in space. So I'm just very uniquely intrigued by that. My practice, most of my patients are virtual, but I'm licensed in New York and Arizona. I see patients in person in Arizona, but again, as I said, most of my patients are virtual. And again, my focus is primarily on the chronic patient. So it may be the chronic pain patient, the chronic movement disorder, or oftentimes chronic neurological patient. In addition to that, I'm the CEO and founder of Naboso, which love that Dr. Stacey likes the products and she uses them. She uses them with her husband as well. So we'll be mentioning those a little bit, but those are a sensory-based product line, which is really perfect for this presentation of a neurological injury because of the level of sensory stimulation that we are experiencing. So you are going to get a good mix of perspectives between Stacey and I.
Okay, so I'm gonna, I guess, begin by kind of talking about um, just different neurological injuries. Not every neurological injury, there's a ton of neurological injuries out there. So we're kind of just going to be scratching the surface on like mainly spinal cord injuries, stroke, multiple sclerosis, some peripheral neuropathies, radiculopathies, stuff like that. So these neurological conditions, they can disrupt the nerve signals responsible for either sensation or motor control and coordination. We see it in the hands, the feet, throughout the body, depending on the specific neurological condition. And this obviously the symptoms are going to be vastly different depending on what neurological injury it is. It could be either peripheral nerves, like that are outside the brain and spinal cord, or it could be more central nervous system, which means from the brain and the spinal cord. But we're going to be talking about how these injuries can affect your balance, your coordination. I already talked about sensation, motor control. Obviously, with those things, we're going to have gait disturbances, instability, um, confidence is going to be low. I saw that a lot with my husband, and I still see it with him too from time to time. And then that fear of movement, or just, feeling like you're having trouble navigating tricky situations or different environments. And there's a huge increased risk of falls and just falling in general, which obviously we want to minimize because we don't want to have another injury on top of everything. So we're going to talk about how we use sensory input and how to improve strength, motor control, stability to really start retraining these systems and try to get some mind-body awareness back into that foot and be able to build these connections stronger. And how the foot is like the first access point that hits the ground first. It has like all those mechanoreceptors, and it's really important for us to work on the foot to be able to build everything up the chain.
Gotta work on your feet.
So, like I said, some of the neurological conditions we're going to be talking about today, stroke, TBIs, which also include concussions. There's concussions are a mild TBI, multiple sclerosis, Parkinson's disease, spinal cord injuries, neuropathies, neuralgias, which also includes like peripheral neuropathies, radiculopathies. But like I said, this is like not an all encompassing list at all. There's a ton more conditions out there. And so obviously we're going to be treating each one very individualized based on like the symptoms and the areas affected in the body. But overall, the shared themes are that there is a sensory loss, we got some motor impairments, coordination challenges, and these definitely impact our gait and falls.
So I love that Stacy just kind of set the base as far as what we're thinking as far as these movement concerns for these individuals. Obviously, movement is everything. We need to be able to move to, maintain that independence. And the simple act of walking is just inherent to being human and socialization and independence and quality of life. So essentially that's kind of the goal of what we're trying to achieve and the power that we're trying to unlock in these individuals. From a sensory perspective, the way that I think about chronic neurological injuries is it's really based off of getting them to reconnect to the sensory side of themselves. And then the more that we can tap into and feel and connect to that sensory stimulation, it allows it to guide us into this movement. Maybe it's using sensory just to feel what upright posture feels like again, or sitting up. Maybe it's initially that, sitting up and feeling your feet on the ground and just connecting to that. And then as it transitions to standing up, what does that feel like? What does it feel like gravity on our shoulders? And then, of course, dynamically as we move. So when I work with the chronic neurological patient, I'm getting them to reconnect all the way to the beginning when we were first born. Actually, this is when we were in utero. The sensory stimulation that shaped how we connected to ourselves and this external world is a gravitational story. And that's where everything begins. And everything, in my opinion, has to go back to that after a neurological injury is understanding gravity. Gravity is this downward pressure that allows us to push up into something and allows us to actually stand on our 2 feet. It is one of the most important sensory constants in the world that if we are starting to have a decline or a shift in our ability to maintain balance or to maintain posture, to move dynamically, it's to reconnect to that stimuli. So not only is gravity a downward pressure, but it is also a proprioceptive or a sensory hug. So when you are trying to feel your body so you can control your body standing up in space, you have to get that hug back. This is where I will use things that are essentially helping you or the individual reconnect to gravity. This could be something like compression apparel. So compression sleeves are essentially hugging the nervous system and our skin, and directly under your skin is fascia. Fascia is connective tissue. And there's actually over 100 million sensory nerves that live within our connective tissue and that saran wrap, that fascial wrap of our internal body. There's 100 million sensory nerves. So by putting a compression sleeve on, you stimulate the nerves, which wakes up the brain. It could be something like weight. Gravity is obviously weight. So when you add weight to the body, like a wrist weight, a weighted vest, this is where weighted blankets work because they're stimulating the nervous system. I love to use weighted apparel. So there's different brands. One is called Kilo Gear, Kilo, Kilo Gear. And they have these little, think like a little credit card that you put in different areas of the shirt and the pants, and it's adding weight, which is turning up the gravity so that you can feel it and your nervous system can connect to it. That, to me, that is ultimately where this neurological story has to start when it comes to movement. So when I do work with this patient as they're going through their rehab, I would say, as you're working with Dr. Stacy, I need you're going to your appointments with Dr. Stacy with compression on, with the weighted apparel. I may have you dry brush and you're going to stimulate all of your skin, and then you're going to do your exercises. We need to reconnect the body to gravity so that your brain can see your physical entity in space. It's a very, very important first step, which is kind of the foundation of everything that Dr. Stacy and I are going to speak about during this 2-hour window.
Okay, so what I want to talk about first is the sensory motor feedback loop that we have. We have that obviously throughout our entire body, but this in the foot, it involves a constant cycle of you get input from the foot, so through sensation and those mechanoreceptors and proprioception, all these different things, and then it sends information about that, what you're feeling, to your brain. And then our brain uses that information to be able to decide what to do, to be able to alter movement, adjust movement, to move a certain way, get out of harm's way, like all these different things. And then obviously that motor component is processed and we actually do the movement. Now, if you have an altered input, then obviously that's the first step. It's already disturbing the whole cycle of events. And then if you have also a central nervous system issue, a neurological condition, then we also aren't interpreting it correctly to be able to have the right output. So obviously, first we want to work on sensation, like Dr. Emily was already saying. That's really the foundation to be able to interpret the world around us. And once we can interpret it correctly, then our brain can also be able to hopefully, over time, retrain itself too, to be able to have the right output, the right timing of stability, to be able to, catch yourself when you're about to fall, all those different things. And obviously, we know with all these neurological conditions, depending on the condition, that you might have more of this reduction of sensation. You might also have misinterpretation of what you're feeling, and you might have also a misinterpretation of what to do based on what you're feeling. So we're just trying to basically reestablish these connections and to make everything work more efficiently and like it's supposed to.
So to go a little bit deeper into the foot specific, because that's just going to be a lot of what Dr. Stacy and I are speaking about. She already mentioned this neurofoot connection. Once your nervous system can reestablish that awareness, then everything starts to kind of fall into place, or hopefully start to fall into place. So before we get into any of the exercises and that aspect of the webinar, I want to first establish and go into the uniqueness of the skin in the bottom of the foot. So the skin in the bottom of the feet, which is very similar to the skin on the palm of the hand, it's called glabrous skin. So this part of your body, everywhere else, is called hairy skin. And then the palm of your hand and the bottom of your feet is called glabrous skin. And we have these very special nerve endings that are based on touch. So touch receptors, they happen to be called mechanoreceptors, but they are touch nerves. So when you use your hand to touch different surfaces, that is, again, stimulating the brain. It's connecting to awareness. It's connecting to accuracy. So one component of how I think with just movement in general, but movement with neurological injuries, is we're trying to reestablish movement accuracy. We need to move accurately. So as you are reaching, here I'm reaching to grab my phone, but as I'm reaching, I need to be accurate for the depth of how I'm reaching for it, right? For the foot, same thing. We need to have accuracy in foot placement. Otherwise, if I don't accurately step off of a curb, I could fall. So movement accuracy very much correlates to fall reduction or injury prevention in these individuals is how we'll speak about it. That is based off of feeling and stimulating these touch nerves, and then you obviously have to accurately interpret it. So when we look at the hands and the feet, special nerves, right here I have it written down, and I'll move my camera over so you can see them. So again, you don't need to know these unless if you want to, but we have 4 main nerve types that are in our hands and in our feet, and they respond to different stimuli. There's 4 different nerves, but there's 3 different stimuli that's coming in. The first one, which happens to be called an SA1, is 2-point discrimination. Now, I'll really tell you what that is, or the best analogy to that is Braille. So the next time you go to an ATM, look at the Braille dots on the ATM, and you will see the different pattern, right? That's actually 2-point discrimination, that you can feel something and your brain can sense the distance between those 2 points. Okay. Now that is also Naboso. So the texture on all of the Naboso products is actually stimulating 2-point discrimination. If any of you have a Naboso product now and it's near you, I would encourage you to just kind of push your fingers into it. And then if you look at the little indents, they look like little Braille dots on your finger. That is essentially that same nerve. Okay. So oftentimes we say that Naboso is like Braille for your feet, stimulating the same nerve. Okay. The next one, which happens to be the SA2 Raffini ending, is stretch. So when you get a massage, you are stretching these certain nerves. I don't know if you've ever put like kinesiology tape on the bottom of the foot. If you do that, that is stimulating skin stretch. So that's one of my favorite stimuli. And for everyone at home, you can buy kinesiology tape on Amazon, any brand, doesn't matter, and just cut a strip and put it on the bottom of your foot, and it will connect and start to wake up the stretch nerves. And then you could do your balance exercises. I actually absolutely love that technique. So that's one way. Another stimuli, if you look at the side, says FA1, FA2, and then there's this vibration under it. So vibration is another very, very powerful stimuli which comes to your feet and to your hands. And where we experience vibration on a daily basis as it relates to movement is with foot to ground contact. Now, every time we walk and we take a step, your foot strikes the ground and you experience impact forces. So I'm going to hit my table for a moment. So this is me walking, right? Just imagine walking and you're hitting the surface. Sound waves are vibration. Okay. So I want you to understand and connect that foot striking ground creates vibration. That vibration stimulates your brain, your nerves, but your brain to help you understand how to control your movement. Vibration through your feet stimulates a balance response. Vibration through your feet activates the stabilizing muscles of your feet. Vibration through your feet actually builds bone density. So that's a bonus for you as well. So vibration is very, very important. Now, here's the thing of where this is very important when it comes to the neurological client, patient, individual, is the shoes we put on our feet greatly affects how much vibration we feel. Cushion in shoes inherently disconnects us from the sensory stimulation of the ground and our feet, particularly to vibration. So I challenge you, if you're working with neurological individuals, if you are living with a neurological injury or a loved one is when you do their exercises, get the shoes off, get the socks off, expose this powerful skin so that they can get that sensory stimulation in and access into the brain and the nervous system. Now, real quick on this, ways again that we can get this. So the 2-point discrimination, that's the different Naboso products. And we have over 40 products you can incorporate for this individual. Skin stretch, consider taping the bottom of the foot, massaging the bottom of the foot. You're waking up that specific nerve. The vibration platforms. Power Plate is a great one. We've actually worked with Power Plate. I've created some programming for Power Plate as a company, and it's so great to just even sit and put your feet on the plate and the plate vibrates. And what's happening is that the plate is mimicking walking, because every time you walk, you get vibration. So it's telling that nervous system of that person whose feet are on the plate and they might not be walking yet because of where they are in their recovery, but it's telling them and their nervous system, this is ground reaction forces, this is gravity, this is how your nervous system is stimulated. You can use vibration tools like hyperspheres, a ball that vibrates. There is what's called a fascia hydrator. So go to Melt Method, MELT, Melt Method, and they have what's called a fascia hydrator. It is a wand. It looks like a stick and it vibrates, and you essentially paint the body with this vibration stick. Oh my God, it gives me goosebumps talking about that thing because vibration is so powerful. Everything is about vibration. So that's very, very important for everyone. Now, what I will say real quick on here is these are 2 fun facts that I always share about the nerves on the bottom of our feet. First is that 70% of those nerves, so picture the bottom of your feet, 70% of the nerves that are on the bottom of our feet are sensitive to vibration. That is the most important stimuli that you could be bringing into your feet. So just think about the shoes. Think about the surfaces you're on. Think about how you could introduce vibration through different tools. Okay. Second one is that this is outside of a neurological injury. The peak sensitivity of the nerves in our feet is age 40. By the time we are 70, we need twice as much stimulation to feel it and perceive it. Throw in a neurological injury on top of that, and now you need even more. Real quick to kind of hit this home as far as the impact of neurological injuries, I'm going to take neuropathy as an example. So diabetic neuropathy, which again is a little bit different than MS and Parkinson's, but it's a disruption in the nervous system. If you take 2 diabetics, exact same age, say weight, everything about these individuals is exactly the same. Boom. You have a diabetic with peripheral neuropathy. You have a diabetic, no peripheral neuropathy. The diabetic with peripheral neuropathy has a 15 times greater fall risk. 15 times. That is massive. That is because our feet and the perception of our feet and the perception of our ground, of the ground, is critical to how you maintain balance and you prevent falls. So please, please remember that as we're going through this entire thing. And as Dr. Stacy goes into some of the programming that she really likes, is please take that with you.
Yeah, we'll definitely circle back on the vibration stuff and kind of a lot of the things that Dr. Emily was talking about, because those are strategies that I use with my patients and strategies that I've used with my husband. And we've gotten so much benefit from some of those things. So I'll be sharing all of that in a second. But first, I want to go ahead and dive into the pathophysiology of some of these. I know I talked about this briefly at the beginning. But each one of these kind of has a unique presentation. And then obviously based on like the area of the brain affected, then you have other presentations that could, come from this. So I'm just going to briefly go over this again. When we talk about like TBIs, strokes, stuff like that, we're getting both usually sensory and motor issues. I see a lot of numbness, pain, difficulty controlling movement. Sensory issues, I see a lot of like problems with touch, the 2-point discrimination that she was talking about, pressure. Some people can't feel pressure. It doesn't even matter how much pressure, or they might not be able to feel light pressure, but they could feel, really intense pressure. Pain. A lot of times we get pain response when you feel anything. So that's a huge thing that we have to also work through in physical therapy, is that not everything is a threat, and being able to interpret what is like a good sensation and what is a bad one is really important for rehab. I see body position, like awareness issues, and then motor control issues. We got weakness, paralysis, spasticity, loss of fine motor or like gross motor movements. Obviously, there's a lot of things, a lot of different things, but lots of issues there. And then for MS, I see both sensory and motor issues. I know most people think that MS is just one or the other, but we do have both going on, because this is an immune system issue. It damages the myelin sheath that protects the nerves and the spinal cord. So we have sensory symptoms that are like numbness, tingling. A lot of people feel that they're constantly tight or stiff. Motor issues, we have this muscle stiffness too. We also have spasms, cramping, weakness, and then a lot of difficulty with balance and walking. Usually, like a lot of weakness presents over time, depending on what nerves are most affected with that. From Parkinson's, we have both sensory and motor issues going on here. Most people think of Parkinson's for more of the motor symptoms. Those are the ones that are very visible, the tremors, the rigidity, all that stuff. But there are non-motor symptoms too. So this can include sensory problems like pain, numbness. Let's see what else we have, like also like loss of smell and stuff like that. And we do rely on other systems to be able to interpret what we're feeling too. So if you have a reduction in one of our senses, then we usually rely on the other ones more heavily. But with Parkinson's, sometimes we also have visual problems, vertigo, dizziness, and stuff like that, which could also alter the input that we're feeling and noticing. For spinal cord injuries, we have obviously both sensory and motor issues depending on the levels affected. So we have like dermatomal pathways and myotomal pathways that you can like look at to see what you would expect to have for sensory or motor loss. You might also have bowel or bladder control issues depending on the levels affected, and kind of how everything is going, if it's like a complete or an incomplete. Neuropathies and neuralgia, we have usually both motor and sensory issues. This is usually peripheral issues. A lot of pain, a lot of burning, sharp electrical feelings, so like numbness, tingling, stuff like that. The motor control problems, this can be like muscle cramping, twitching, also just muscle wasting or atrophy from like just obviously something being either impinged or just disuse. For radiculopathy, usually this is also a peripheral issue. So we have both sensory and motor problems, weakness, decreased dexterity due to nerve compression. We might also have a lot of problems at the bottom of the feet with radiculopathy, or you're not getting that signal all the way down to the foot. So people really can't feel very well down there. So with all these issues, obviously, if you're not able to feel, then you're not able to move correctly. So that's why it's important to know which ones are just sensation and which ones are motor. And most people have a little bit of both when it comes to neurological conditions. So what I see in clinic, a lot of foot drop and toe drag. I think we kind of talked about the mechanoreceptors, and I know Dr. Emily was mentioning some that you have to kind of know how to respond to things too, but we have the stretch reflex in our body. So when you're walking and stuff like that, you have this stretch that happens on your Achilles, and that pressure and that gravitational pull downward, it teaches us to be able to know when to like lift up our leg and to be able to swing through with that gait phase. And so if you don't have obviously that, if you're not able to walk at a fast pace, then you're not getting as strong of a stretch reflex. And if you don't have like the feeling in your foot, you're not going to always know when to pick it up. So we rely on reflexes, but we also rely on these inputs. So foot drag and toe drag, it's not just from motor problems. Sometimes it's just from sensation loss. Shuffling gait, reduced step length, all these things. If you have Parkinson's, most people want to like do everything small. So they have trouble walking through small spaces. They also like do everything tiny. So the big goal there would be it's called big, like we do the big three things. So we do large movements, try to do like high amplitude movements just to try to get them to actually start overcoming some of those problems that they have. I already kind of talked about decreased push-off power. So if you're not really sure of yourself and you don't have the confidence to walk, you're probably not going to be walking really fast, right? And you're probably not going to be like really using all the muscles that we do usually when we walk. So you're probably just going to be picking up your feet more so. So then we have the push-off power isn't just for calf strength, also like hamstring strength, glute strength, and hip flexor strength. Poor single leg balance. Balance is really, really affected. Not even just single leg balance, tandem balance, feet together balance, like all those things are usually something that we work on in clinic because those are always big problems and we want to reduce people's risk of falling. Delayed or absent proprioceptive reactions. So this is like I was saying that like basically where's your body in space? So if someone's pulling you backwards, which is a test that we do for Parkinson's, we should also take a step, right, to like catch ourselves and protect ourselves. But if you don't have that sense of where you are in space, you have no idea when to react. So this is something that you can train. So you can train through different exercises and different sensory inputs. We'll kind of get into that in a second. And then definitely some compensations at the hip, knees, spine with walking. I see a lot of like back movement more so than like hip movement because you don't feel comfortable walking normally front and back. So you just tend to like rotate a little bit more and hike up that hip and stuff like that. So that's kind of what I see. All right, some functional implications. I talked about higher risk of falling. My husband's fallen a few times. I think the last time it was like 6 months ago. So he's been doing really, really well. But obviously, every time that you fall, if you're older, then you have a higher risk for a fracture or something else to happen. And somebody that's older that has a fracture, that could be like the beginning of the end. For some people that have like osteoporosis and stuff. Increased energy expenditure with walking. So this is one of those things that if you're using different compensatory mechanisms to do the movement, you're not walking efficiently. And with efficient walking, then we actually don't burn as many calories. We can do that movement in a more energy conservation sort of way. So teaching someone how to walk better actually helps save their energy for other things that they want to do with their life. Difficulty navigating uneven surfaces. This one's tough. And this doesn't only mean like foam pads and hills and stuff. We're just talking about like gravel or dirt or any sort of change in like a surface. A tiny little hill can like make the biggest difference for somebody that has a neurological injury. Other secondary issues, like I said, that the back compensations that I see, hip pain, back pain, stuff like that, knee pain, because you start to change how you move. For instance, my husband, when he was doing squats, he would always want to pull his knee out so far that it would cause his knee to start becoming problematic. And it's still kind of problematic because he was relying more so on pulling that knee out because he was afraid of what would happen if he kept his knees in this direction. So he wanted to use another plane of movement to perform that activity just to be able to feel like he had more control. And with all this, we have reduced independence and confidence and mobility. So this is huge for the quality of life portion. We want to always get people back to doing all the things that they love and enjoy and want to do, and be able to do so without feeling like they're scared of what's going to happen or constantly thinking about like, what if I fall? Like that's not fun.
Okay. And then just to kind of confirm with everything that Dr. Stacy was saying is I have found, and I'm sure she's seen the same thing, that subjectively a fear of falling is a huge contributor to falls. That if someone is very apprehensive in their movement, which just means there's a lack of movement confidence, there's a lot of research that shows that that is a huge contributor to fall risk. So the more that we can improve foot awareness, ground awareness, body awareness, foot strength, every component that we're going to be speaking about, for every increase in awareness and balance, there's a huge jump in movement confidence, which means there's a huge reduction in fall risk. So really, really interesting to see that. So what I want to do is go back to kind of this sensory side. So we can lay the tone as we're starting to get into some of the exercises now and talk about body schema. And then we're going to connect to our body schema. So our brain has a internal picture of our size and shape in space. So if we were to shut our eyes, you should see, and your brain sees kind of the morphology of your body. It's a internal map of your size and shape in space. And then we use that as we navigate the external world. So I'm going to give you a quick example of this, and then we're going to connect to ours. So, and this is the example that I always use. So if you've ever heard it, I do apologize. But let's imagine that you are in a crowded restaurant and you're having dinner, crowded restaurant, you have to go to the bathroom. They're like, oh, so now you have to get up and you have to weave your way around all the tables and the chairs. And you are making this subconscious, so this decision in the background, you're not aware of it. But as you're making your way to the bathroom, you are finding different distances. Some of the chairs are this far apart, some are this part, some are this close, and you're kind of navigating. And without even thinking about it, you are deciding if your body can fit between those chairs. So in some instances, and I'm sure everyone has done this, that as you're navigating, you're walking straight, or you're like, oh, no, I got to squeeze this way. Or you walk and you see two objects and you're like, I'm not going to fit between there. That is your brain in the background connecting to your morphology and knowing how much space you take up, right? So that is called body schema. And that's just one example of how you do it. It is perceptual awareness of your body relative to external objects, other people, etc. Okay. This, again, go back to the beginning of what I said, to me is at the heart of where neurological rehab has to start. Because if you don't have an awareness of where this physical canister is moving, to me, it doesn't matter how much quad strength or tricep strength you have. It's a sensory story. And that's where Dr. Stacy, and I absolutely love her approach, and we align that it's a sensory story that we have to be taking when it comes to neurorehab. So these are just a few that I had mentioned already, right? We had mentioned wrist weights. The Naboso sensory sticks are textured and they're weighted. So holding them, just holding the sensory sticks will wake up your brain and connect to your body. You can use other tactile. So of course, Naboso texture, vibration, we spoke about dry brushing. I mentioned briefly, but I love dry brushing. And whenever I have a neurological patient, I'll tell them to dry brush their entire body, and then they're going to do their breath work. or then they're going to do their exercises, or then they'll do their stretches, whatever it is that I'm having them do. Compression, mentioned that already, compression apparel, kinesiology tape, athletic braces. Okay, so these are ways to kind of turn up the sensory so you can feel your body and your brain can see it. Okay, so now what we're going to do is we're actually going to connect to our schema. So what I'm going to have you do is you have a choice. So you could either be seated in a chair, and if you are seated, you're going to have your feet flat on the floor. Your palms can be facing down or up, your choice. And then your eyes will be shut if you feel comfortable. So the eyes shut just helps you connect inward. But of course, we want everyone to feel safe. So the eye shutting is kind of your component of it. Okay. If you feel comfortable standing, why I like standing all the way up just like this is that now we're in gravity. So there will always be more sensory stimulation when you are standing than seated because of gravity. Okay. So are you standing with your eyes shut and your arms by your side, or are you seated in a chair, or theoretically you could do this lying as well? So just kind of note that. Okay. And then we'll go through it, this version, and then you could play with it and try it again and maybe stimulate your skin. If you have the neuro stick from Naboso, you'll just kind of stimulate, maybe do a little vibration stimulation, and then you do this body schema practice. It's your choice. Okay. But you are seated or standing in your position. Everybody is going to shut their eyes, please. And I'm going to cue you to start to see slash feel your body in space, okay? And whatever you see in your mind's eye, I want you to try to feel. So we're interplaying between the seeing and the feeling, okay? So as you are seated or standing, I'm going to do it standing because it's just, I'm going to connect to my schema as I'm teaching you your schema. So we're here. So I'm here doing this. So I'm standing here, nice and relaxed. Eyes are shut, seated, standing, line. You get to choose. And we're just going to relax into our body a little bit, right? So just kind of little wiggle, wiggle, wiggle if you need. Get settled in your body, and then your eyes are shut. And I'm going to have you start at your head. And I want you to start to see the size and shape of your head as it's sitting on your shoulders. And as you see your head, can you feel how big your head is? Can we just start to connect to the size, shape, see it, feel it as it's sitting on our shoulders? And I want you to hold that image and sensation of the head and then work your way down your neck, across your shoulders. And can you feel slash see how wide your shoulders are? How much space are your shoulders taking up? Hold that image, and I want you to work your way down your arms, past your elbows, forearms to your hands. Hands by your side, or maybe your hands are on your thighs. Can you see slash feel all 10 fingers? Maybe give them a wiggle if you would like. And then let's continue down our torso to our hips. And I want you to feel slash see how wide your hips are. How much space are your hips taking up? And then continue down your upper thighs, past your knees, to your lower legs, all the way to your feet on the floor. And as your feet are on the floor, I want you to feel slash see how big your feet are. How much space do your feet take up? Can you feel all 10 toes connecting to the floor? And I want you to hold that entire image of your body from your head to your shoulders, to your hips, to your feet. Can you see it? Can you feel it? Hold that image And could you feel just outside that image? Do you feel like energy or a space just outside that physical body you're connecting with? That is called your peripersonal space. And just connect with that image a little bit more. Feel it, see it, connect with it. Again, maybe wiggle the toes, wiggle the fingers. And then when you're ready, I'm going to have you slowly open your eyes. Okay. So that was a small practice or exercise in connecting with your body's schema. Now, that may feel kind of similar, like maybe meditating or like a mind-body practice. Tai Chi and different mind-body methods are very connected this way. And if you've ever read research around certain mind-body practices, Tai Chi very specifically has a powerful effect on the nervous system and the connection of mind-body awareness. We lose mind-body awareness or our perception of body schema with age. Just with age, we lose it. And that is a huge contributor to fall risk with age. Throw in a neurological injury and you are disrupting that even more. Okay, so it is a very simple practice to start to connect with the size and shape of this physical canister as it's moving in space. And then I would challenge you, if you are having a hard time feeling your body as we did that, how would it change if you had compression apparel on? How would it change if you had a weighted vest? How would it change if you dry brushed and then you did that? Right? Just kind of play with a little bit, knowing that this is a brain-based process, which is sensory. Okay. What I want to go in very similar is a foot specific way of doing this. And this will be connecting to your foot posture to enhance mind foot awareness, because that's where a lot of this story starts. Okay, so I will now invite everyone to stand. Again, if you were seated on that practice, I'm going to invite you to stand if you don't mind, and just kind of humor me again on this one. Okay, now on this one, if you don't feel comfortable shutting your eyes, you don't have to. You could just kind of gaze into the distance, or maybe your hand is on something lightly and then you feel comfortable shutting your eyes. So my hands are on the table, just lightly touching it. Whatever you feel comfortable, I invite you to again shut your eyes. Again, your comfort level. Hands are holding on by the side, and I'm going to have you just relax into your body again. Okay, maybe wiggle your feet, lift your toes, wiggle your knees, and then get settled. Beautiful. Now let's focus down on our feet specifically. We're going to zone in to our foot awareness. And as you stand here nice and relaxed, I want you to start to focus on your foot pressure. I didn't use my disclaimer. I really would like if you had no shoes and socks on right now. So sorry, I forgot to mention that. I'm just always barefoot. I assume everyone is. So no shoes and socks. So if your shoes and socks are on, you would want to take them off for this. All right. So we're standing here nice and relaxed. Okay. Focus down on your feet as you are standing on the ground.
In progress.
So as you're standing there, I want you to just start to feel the pressure under your feet. Now, wherever you put the pressure under your feet, it starts to tell a story of your foot posture. And then your foot posture ultimately influences your entire body's alignment. So let's start to focus on our feet. Eyes are shut. And I want you to start to notice, do you have more pressure under one foot versus the other foot? Or is your pressure pretty balanced between both feet? right? We're just getting curious, focusing and feeling that pressure. And continue focusing down on your feet and the pressure. Do you happen to notice if you have more pressure in the back of your feet or maybe the front of your feet? And then finally, do you happen to notice if you have more pressure on the inside of your feet or the outside of your feet? So we're just kind of checking in. Where is our individual pressure? Feel what that feels like. And then I'm going to help everyone try to find a little bit more balanced pressure. If everyone could please lift your toes up off of the floor. And as you do that, I want you to feel your foot tripod. So under the first met head, the fifth met head, and the heel. So the inside of the foot, outside of the foot, and then heel is making a tripod or a triangle under your feet. Spread those toes as wide as you can and place them back down on the floor. Now I want everyone to just ever so slightly connect into your toes. And then let's reassess where you feel pressure. Just doing those 3 little steps, tripod, spreading toes, and connecting your toes into the ground. Do you feel more balanced pressure under your feet? You should start to feel a little bit better connection to your feet. And then I invite you to open your eyes and you may have a seat again. So that foot-specific connection that we were playing with is one that I also will do or have patients do before they start doing their exercises. It's really building mind-body awareness, right? We're just trying to get the body to connect to itself. Okay. And then that will transition into all the other exercises that we would.
Okay, we're back. So now all the fun stuff. Like Dr. Emily was saying, the finding the tripod is so huge for patients. I found, and luckily at my practice, we have force plates, so we can see also like visually that visual feedback. If people can't feel, if they don't have the sensation, like my husband doesn't have sensation on the bottom of his foot, he can't really feel, even though he's trying really hard to like anchor and like feel that. So having that like extra visual component sometimes is helpful. So it tells us how much force is on each leg. And so he can like in real time figure it out and get the 2 lines to overlap and cross. If you don't have a force plate at home, it's okay. Actually, I have a lot of my patients do this with 2 scales. So they just stand on 2 scales and obviously like half of your body weight should be on each one. And so if you're not doing that, then you can quickly in real time see what you're doing and then try to even things out too. And maybe use that as like a starting point to be able to figure out how to feel where your foot is in space too. So just a little tidbit there, but thanks for that exercise, Emily. I'm actually like super relaxed right now. Okay, let's talk about the movement re-education or like a rehab framework. So sensory, foot to core sequencing or activation, and then neuromuscular re-education. Those are like the big 3 things that we work on. So, can we get the input better in the foot? Or like the toes or wherever in the lower leg, all that stuff. And we can use obviously multiple tools, which I'll share in a second. And then how can we like integrate that? So now we're trying to, now that we have the foot, we feel the foot, how do we get that to do what we want to do and be able to integrate with different types of movement? So is our trunk moving with when we're walking, or are we just stiff? Are we like, doing this cross body movement, or are you going more side to side? So now how do we integrate that into different exercises to also improve just coordination, which also helps with like trunk stability, core strength, all that stuff. And then neuromuscular reeducation. This is kind of something that we're kind of doing all the time. So we're trying to reeducate. So it's that mind-body connection to reestablish for motor control and for output. So getting things to like function better, to do what you want it to do when you want it to do it, you know? So it's that whole, if you don't use it, you lose it sort of thing. Age is a big factor for a lot of this. So as we get older, like Emily was saying, we lose a lot of this because we also don't do stuff like this all the time. So taking the time to like go back to the basics sometimes is even huge in like my own practice and my own training to be able to like reestablish something that I'm doing wrong. Like when I had my Achilles injury, I needed to also reestablish some of this stuff too. So you can apply the same framework to other injuries, not just neurological conditions. Okay, so our rehab priorities, we use sensory stimulation, a lot of different things. So we have like the neuro ball. These are my shoes. I have the Naboso insoles, which is like the same as the neuro ball in there. Sometimes we use like a disc that has obviously like this sort of texture. There's many ways you can include sensory, vibration, tapping, anything like that, even electrical stimulation. So we have, this is literally on my husband's desk. We have a Compex. So this is electrical stimulation. He also has functional electrical stimulation. So he has the BioNS on his leg to help him with his foot drop, to lift up his foot when he's walking so he doesn't trip. So some of that stuff we can use to just kind of get everything functioning better. So we use that as like the very basic beginning thing of rehab, and then we build upon it. So that's what we always usually start with. But you can also use vision or other systems to be able to help you feel a little bit better, to get more of that sensory input. The neuromuscular control, like I said, that's that foot to core activation. Are we doing this cross patterning? How does that look? How do we reestablish those and make it non-compensatory? Strengthening. This is a huge missing piece, in my opinion, in neuro rehab, like traditional neuro rehab. I didn't see a lot of that in Logan's like outpatient rehab at first. They mainly were focusing on neuromuscular reeducation and gait training and balance training. Those things, that was kind of what they did the entire time there. And obviously they have so many like things that they want to work on. They can't possibly like fit it all in. So obviously I would add in the strengthening stuff for him, because the stronger you are, the better you can actually start to integrate some of this stuff and move better and feel more confident too. If you know that you can pick up 100 pounds, then you know that like you feel okay carrying a 20-pound sandbag. You know what I'm saying? So all this stuff, it's so helpful to get ankle, calf strength, glute strength, quad strength. So a lot of spasticity is going on within these like tissues, depending on the injury. So obviously sometimes you have to break through that tone by getting the opposing muscle group stronger. So that's kind of one strategy that we can do for that. Balance training, we want to do things that are both like static, so like standing still, dynamic, and then reactive. So how does your body react? So sometimes I'll be pushing my husband or like having him do like a falling lunge. So he has to catch himself and see how he does with that. And obviously his falling lunge at first was like a baby step. And then as he felt more confident with it and could feel what he was doing and can like feel that he's not going to fall, and he was having success with that, he would go a little bit further and like go a little bit longer and then start to move side to side. So all these things, you know, we do throughout our day usually. And so integrating those back into rehab is really crucial to get people back to their life. And then our functional integration with ADLs. So that's just things that we do throughout our day. Community mobility. So going out into the grocery store, going out into the community, the mall, those things are huge. So like, it's not, can you only do it in this closed, safe environment, but can you do it as you're walking across the soccer field at your kid's game? You know, do you feel comfortable being in those settings and now moving the normal way that you used to move? Or do you like freeze up, tense up, and then go back to your compensations? So just getting all that to be a little bit better. And then sport specific. Obviously, there's a lot of former athletes that want to get back to themselves and feel like themselves. Logan was a power lifter, so he wanted to do stuff like that. So was that part of his rehab plan? Absolutely. So all those things are really important to integrate. And we kind of sometimes do a lot of them at the same time. Okay, here's the really fun stuff. So grab some water. All right, so sensory drills. So we kind of talked about like barefoot balance work. I love people being barefoot. People that have neurological injuries, they don't love being barefoot. And for one reason or another, I think they just feel safer and more comfortable when they have shoes on. They think that it's protective, but really then we lose a lot of that sensation that you would be getting, or the vibration from what you're doing, or the gravity, all those things. Like cushion shoes are the worst thing for most people that have neurological injuries. So being barefoot, great. And it doesn't have to be standing, it could be like seated, using things like the neuro ball, using any sort of like vibration plate. We have one at the clinic. We do it, I have people do it on their hands, sometimes just sitting on it on their butt, because you want to wake up everything. So the better our nervous system is working, the better we can do these exercises that we want to do in rehab. So we got that this year, and I think it's been really helpful. And then foot to core sequencing. So I have a couple exercises kind of like scattered throughout here, but do you guys know, I don't know if you know what woodpeckers are. I'm going to show you. So woodpeckers are like when you're standing and you're trying to go forward and then catch yourself and then come back. So your feet are staying flat and you're just kind of rocking. So you're learning how to use that tripod that Emily was teaching us about, starting on it like basically on your tripod, and then learning how to shift your weight to your forefoot, which is something that I see anybody with a neurological injury struggle with. So they lack this forefoot sensation, this forefoot control, and with that they have lack of that push off, lack of that strong swing phase, all of those things which could help their gait cycle. Suitcase walks and marches. So in this like top right picture, he is doing some like suitcase walking. So obviously suitcase just means that like we only pick our suitcase up on one side, right? So it's just having something that's going to be offsetting you to be able to challenge that like anti-lateral chain stability. So obviously you're going to have to stabilize and walk. And so one of the things that Logan actually fell with early on was he was carrying a bag of sand in the house. And so we started to integrate stuff like this to be able to get back to that. And the other day he carried like a 60-pound bag of sand, no problems with one arm. So these things are also very functional for people. Stepping with Pallof presses. So like this is like walking sideways, not in my gym, but it's kind of like if you have a band coming this direction and you're going to be walking sideways. So obviously we're working in a different plane of motion with that exercise. And the further you get away, the harder it is, because the band gets a little bit stronger too. And then you have to decelerate on the way back. So this is getting people out of the frontal plane and, getting them into the sagittal plane, or it is the frontal plane. And just kind of moving in different ways. And then the Pallof portion is like an anti-rotation exercise. So that's like getting that core connection to be able to make sure that we're transferring energy from our feet all the way up the chain, which is what we do when we walk. First string training. So front foot elevated calf raises. So calf strength is really important. I like the front foot elevated one because people can load that up and they feel safer than doing a single leg calf raise. And they also can like offload the weight. So when you're doing a front foot elevated calf raise, you're like this, and you can do this one, or you can do this one. So two different ways that you can do the front foot elevated calf raise to work on that calf strength, that push off, and just feeling more comfortable with like some pseudo single leg balance work. Elevated straight leg glute bridges. This is just like with your feet on a bench or a box or something, doing just like glute lifts. I think it's more important to work on hip extension with the legs straight, because that's what we do when we walk. So working on that and then kind of breaking out of some of those synergy patterns and that spasticity is really important for people. Step ups and step downs. Obviously, navigating stairs is tricky at first for a lot of people and scary. And so there's many patients that I have that literally they decide to just live on the first floor for a while so they don't have to go up and down stairs. So getting them back to be able to navigate stairs and feeling confident with that will give them like a huge piece of their life back. So that's really important. Hamstring curls. There is a huge hamstring strength loss after like something that's neurological. When you have when you have this impairment or alteration in what your body should be doing with like different inputs, it seems that your hamstring doesn't want to like function. So I see a lot of people, they basically just swing the leg through, or they'll hike up the hip and then rotate around or circumduct versus bend the leg and then progress it forward. So working on, this is kind of like some of those isolation type exercises. Let's break out of these synergy patterns. Let's get into some isolated strength work, and that helps to become integrated into their walking patterns. And so you'll see the bottom right picture is like after I had him do hamstring curls, I had him do hamstring kicks into the wall. And this is the same exact thing that our hip does when we're walking. So obviously that's an integrative exercise, but it's also working on glute strength and hamstring strength, and also single leg. Hip flexor lifts, this is not only good for the hip flexor itself, but the anterior tibialis muscle, which is the front part of the shin muscle, which is something that people really struggle with if they have foot drop or some like motor problems in that lower leg. So working on that, once again, strengthens not only that part of like the front part of the anterior chain, but it also works on balance too, because your stance leg or your stable leg is in hip extension as you're lifting up. So it's really a great integrative exercise to help improve walking and balance. Balance. I love the Captain Morgan exercise. That's the one on like the bottom left there. If you've never done it, it is like the hardest exercise ever. You can do like squats with it. You can just lift the ball up. So you're basically doing hip abduction as you lift your leg up. And my goal is to get people to be at that single leg, not use their hand, and then just let go and hold the ball in that position about 90 degrees to work on hip abduction strength. And then you can, like I said, do like RDLs with it, or you could do squats, or you could do just little like taps with the ball, or you could do lifts up and down. It works on obviously hip stability, which is huge, as well as a single leg balance. Perturbation training. So this is like, you can kind of move people side to side or just like tap them. I've done this a lot with my husband. We used to do this at home all the time. So I would at first have the gait belt on him, and then I would just, have him close his eyes and then just try to feel where he is in space and just do tiny little nudges to see how he reacted. So this is some of that reaction-based training. You can also do it with, I like to hit people. This sounds terrible when I say hit people, but I like to like nudge people with a stability ball. So I'll have them do something like lateral walking, and I'll just nudge them with the ball to see how they react to that. And I think this is really important too, because we don't live in a perfect, safe, closed environment. We live like, anybody could bump into you at any time when you're in the grocery store or in the mall or wherever, at the airport. So let's just expose you to those environments and see how you do and get stronger at them and feel more confident with those different things. So that's pretty big. I like doing those things. Rotational reaching. So different types of reaching on either two legs or like a staggered stance or single leg if they can. And then obviously we're walking on uneven surfaces. So the top left picture is an uneven surface like seated. That's kind of where we used to start with these exercises. So to work on that foot awareness of that, where it is, to make sure he didn't roll his ankle. And then we obviously started working on like going over these steps, side to side. We have like different types of surfaces, some that are more squishy, like this one's pretty squishy, and then some that are a little bit more like hard too, but and then some that are like wedge shaped, so that are like angled like this, once again because it's real life, and real life is different and it's challenging. So as many things that we can expose someone to, that's definitely like what we need to do. All right, gait training. I think I have in like the next picture coming up, but pole walking with partner. I'll show you guys that. Sorry, my computer's like tipping. We like to use two poles. We use like just the stick mobility sticks because we have them at the office, but to put like them in someone's hand. So like the first person has them like this is the patient. And then I have them that I'm just holding them in the back like this. And the whole goal is basically this rotational based walking. And you're the person in the back is guiding the movement. So my rotation and my movement pattern is going to be influencing the person that I'm working with. And so this is really big to work on reestablishing normal gait patterns. You know, you'll notice that when you're doing this, you can influence their speed, you can influence their push off, you get them walking faster and better, and it's literally tremendous. And then it does have carryover too. So immediately after, we'll do walking without the sticks, and the walking is better too. Now, the next day, is it the same? Probably not, but it's something that's why you have to do this so repetitively that it becomes like you're constantly like working in that new non-compensatory movement pattern. So that's something that we do. Heel to toe push off. I'll show you that one. So like I said, push off is a big thing post neuro injury. So I have people do like heel and then toe and then step back and then heel strike, toe push, and make sure they get through that full range of motion, because most people, they'll just do this. And they'll just pick up the foot without ever doing any sort of push off. And when you get that push off, you get that stretch reflex of the hip as well to know to pick up the leg. So it's really important to work on the ankles influence up the chain. Metronome based walking. This is really big. People that have like Parkinson's or really just any neurological injury, you can put like a metronome on and have them try to hit that beat. That's pretty cool to see, like, because it also has the same influence like when you're trying to walk with the poles, because you're basically relying on a different system to help whatever you're trying to accomplish. So dual tasks are always going to be better than just one thing. This is kind of what I found in neuro rehab, that it's like if you just walk, not as good as if you walk and listen to music, or walk and do a cognitive task, or walk and try to match someone's pace. So that something that's like externally driven is going to be a better influence on your walking too. And it's going to really help with your speed. Hurdles are a traditional physical therapy exercise. And then some integrated exercises like twisters and split stance. So this is with a cable machine. You have two cables and like you're in this split stance position and you're pushing and pulling. So this is the same rotation that we get when we're walking. And you can obviously do like single leg if you're there at that point in your recovery, or just even just like normal double leg stance. Multi-directional lunges, forward, side, rotational. It's really important for us to move in different planes of motion. There's 3 main planes of motion. And if we only ever train one, then we're really kind of doing our patients a disservice. So I always make sure to integrate all 3. B stance, rotational RDLs with the foot tripod focus. Once again, this is like that rotational transverse plane. It's also working some balance, and we're getting some posterior chain strengthening and also like some shoulder work too. So it's really great for that mind-body connection and then that foot to core integration. I already talked about the lateral band. I think that was repetitive, but all of those are good exercises. Some tools and strategies. So orthotics, AFOs, Logan has gone through 8 AFOs at this point. We started with all the rigid AFOs that they recommended to him in like the hospital and inpatient rehab. I have some mixed opinions about that, because what it does, if you have a rigid foot plate, it prevents push off, right? Your foot can't move, like the forefoot or like the toes, they can't extend. So then now you're further causing this compensatory strategy, because you're going to have to like just pick up the foot to move it forward versus like getting that push off. And so he had a rigid AFO for probably, I want to say 4 months. And then we moved to one called like the Smart Step, which was like a half foot plate. So then he was able to extend his toes. And that's when we started to realize like he didn't have much calf strength. And if you don't have much strength in your calf, how are you going to be able to push off? So, right, it's like not just about being able to have the movement, the mobility, but now we also have to have the strength to be able to not compensate with walking. So It was at that point we realized that we never wanted to do a rigid AFO. So obviously it just depends on the person. Like if someone really needs that like extra support and that it helps them and they're more confident with it, just makes them feel safer, then you have to do what you got to do. But we have now switched to the BioNest, which is the functional electrical stimulation. You can see it in this bottom left picture. So it helps stimulate the peroneal nerve to help lift up his foot. It's still like, it's not great because I think it's based on like this timing mechanism of where the sensor is to be able to push or lift the foot up. So I don't know if it allows him to get full push off, but it allows him to get a lot more push off. And the cool thing about him and his situation is that we don't have to always use it because he can actually do some lift off by himself. So we take it off as much as we can. So we can work on also integrating that push off and then we put it back on and then now he can start walking a little bit better too. So it's like a back and forth thing. You got to find what works for your patients or yourself. External cueing, I think we already talked about like the metronome. There's also things called laser lines that you could like try to meet the laser. There's also like blaze pods. I love using blaze pods. It's more like an external focus. So you have a dual task. So there's an extra cognitive component. So if anyone that is like has a cognitive problem too, this is great. It's great to use blaze pods to be able to like tap things. So a picture that is the bottom right picture. And it makes it fun. Like it's more competitive and I don't know, they light up different colors. So it's pretty fun. Mirror therapy, we got a mirror for his mirror therapy stuff. Once again, I think I mentioned this before, all the research shows that if you can use more systems, more sensory input, you can have better output. So we're talking about not just like proprioception or like touch and feel and those things. We're talking about visual. Then we're talking about like, smell. Like we haven't really used smell, but you could probably figure out a way to do that. But the visual component, it's easy to integrate into rehab. So mirror therapy is huge. Ours looks a little bit different. It's like a stand, but it's good for hand or foot stuff to like reestablish that mind-body connection. This is stuff that I would do like kind of earlier on in the day, and then to try to reintegrate this into more of functional based activities. So, but it's good to like wake things up, and then also wake up the nervous system. So the more ramping up that you can do of your nervous system, the better you're actually going to get for physical therapy. Home program essentials. I like to give people like a daily routine. I think it's like brushing your teeth. You have to do it repetitively to be able to get something out of it, especially for people that have neurological injuries. I just think that repetition is key. So as finding a way to integrate this into their life, it could be morning, could be afternoon, evening, whatever works for them. And then making it obviously like adaptable to whatever time constraints they have, whatever equipment they have access to, stuff like that, I think is really important. Some other technology that you can use, I've talked about the force plates to be able to like figure out weight distribution, textured surfaces. We already talked about lots of that with the neuro ball and all that stuff, and neuro stem devices. And then I think we talked about it already, but like weights, using like ankle weights, it's really important to help improve just the sensory input. So we have we have a anti-gravity treadmill at my facility, and I'll tell you that Logan doesn't like to use it because he can't feel when he's like lifted up, right? So the more offloaded he is, the worse he senses where his foot is in space. So the more pressure, the more we do ankle weights on the affected leg. You can do ankle weights on the arms too. You can do the weight vest strategy. Anything like that is actually going to improve the overall input, the sensory input, and it really does help. That's also why I like to do heavy lifts, because when you're lifting, when you have a heavy squat on your back, guess what? Now you have way more weight through your feet, and you can really start to kind of reestablish those connections. So those are just some strategies I like.
I love that. And I find it really interesting, the anti-gravity treadmill, which just kind of hits home the importance of feeling your feet, feeling grounded, feeling just kind of the weight on the feet and how that connects to the brain is really, really powerful. I want to just mention real quick on anything with the vibration. The way that I recommend vibration for my patients, if you're using a vibration platform, is you could either, if you're non-ambulatory and you're just seated and your feet are on the platform, then typically 10 to 15 minutes is where you want to hold the stimulation. That's where most of the research sits around, is that's kind of the dose of vibration, 10 to 15 minutes. You can, though, on the platforms, if you are standing and ambulatory, you could do your different exercises on the vibration platform. So you could step on and off of it. You could do different balance exercises. You could do squats on the vibration platform. So you could just shift whatever you were going to do on the floor, and now you're doing it on the vibration platform. So you can do it in a couple different ways based off of how you want to do that. And another benefit of vibration platforms is that it increases microcirculation, which is really good for any of the radiculopathies and neuropathies and disruptions of the nerve fibers, the peripheral nerve fibers themselves, is that vibration has been shown to increase microcirculation. And all of our nerves, have itty bitty blood vessels that go to them, which is part of how they stay repaired. So something to think about in that. What I do want to share now is a concept that is based off of how our brain and our nervous system maintains balance and dynamic balance and static balance, which is the name of the game of everything that Dr. Stacy was sharing as well. So we maintain balance through 4 primary input systems. We have our eyes, our ears, our joints, and then the skin, which we've covered already. Our eyes, ears, joints, skin, and they all work together to wake up the brain to control your balance statically and dynamically. Now, the way that they work together is they all contribute a different percent to keep you stable. And if you take away or you disrupt one of these 4, the way that our nervous system is designed is that it will upregulate the remaining systems to help keep you stable. Hope that makes sense. So let's say if you have these 4 systems and you have neuropathy, that means you have a disruption in one of the 4 systems. So to maintain your stability despite the neuropathy, your nervous system is going to upregulate the others. Now, if you cannot upregulate the others, then you will not be able to be stable, sufficiently stable, and you could still fall. Hopefully that's making sense. Okay. And I'm going to go into that in just a little bit more in just a moment. But before that, I want to kind of hit home a little bit on how these systems are stimulated. So your visual system is oftentimes the most dominant system. So when we do something that requires balance and stability, maybe you're standing on the kinesis board, you're on a wobble board, a BOSU, or you're just standing on one leg or walking across the room. Your visual system is almost always the dominant system of how we create a strategy for stability. Okay, that is what we're taking in. That's keeping our eyes fixated on a certain point. But I want you to also appreciate that your eyes can represent eye muscle movements. So when you do eye movements, eye exercises like a saccade, or you're tracing, you're following, whatever you're doing with your eyes, as far as eye movements, what this does is this upregulates a part of your brain that controls large motor movements. It happens to be called your basal ganglia, but it's part of your brain. And this is where research has shown If you do eye movement exercises, you can get an improvement in balance in neurological injuries. There's a lot of research around MS in doing eye movement exercises. So I just want you to understand that. Some of my favorite eye movements, eye muscle movements, is a saccade. A saccade is kind of like a ping pong ball of your eyes that you would look to the right and then look to the left and then look to the right and then look to the left and the right and the left and the right and the left. And your head is not moving. So you're kind of going like that with your eyeballs. Okay. So that's one exercise. I like to also do directional gazing or looking, that I will have people stand and then I'll have them look up and then look center, look down, look center, look up, look center, but they're doing it off of my cues. So they have to listen to what I'm saying and I will give a direction and then they'll look and then go back centered. They'll look and then go back center. So it's an eye movement based off of also listening and reacting to what I'm cueing for the client or for the individual. So those are some of the eye movements. You can do an infinity where you're actually holding something. So you have something in your hand and then you're moving it and your head doesn't move, but your eyeballs are following it. That is another eye movement exercise. Of course, you could keep the object straight and then turn the head and not move the object. That's another eye movement exercise. But any eye movement exercise you're doing, I just want you to take away is stimulating the brain, the part of the brain that controls gross motor movement or large movement, eye movement exercises, and then visual input. Okay, your ears are going to represent the vestibular system. So that's the inner ear fluid. That's how we maintain balance, and a lot of the perception of being upright is based off of the vestibular system. Your vestibular system is the first sensory input system to fully develop in utero. So we are actually connecting to postural perception in utero even, which I find quite fascinating. And that's by the 5 months. 5 months in utero, the fetus has a fully developed vestibular system, which means they can also hear. So watch what you say. 5 months. All right. So that's something very powerful, but also your ears represent rhythm. So doing something on rhythm. Dr. Stacy mentioned a metronome. So metronomes, I love using metronomes. You can use songs, you can use the rhythm of the song, maybe a song that has kind of like an easy beat to follow. A lot of group exercise songs, like a step class, right? So they're kind of designed to be with a very audible kind of BPM that you are maintaining, and then can you hold that rhythm? Humans are uniquely responsive to rhythm, and a lot of that is based off of walking. And in utero, when we are developing in utero, we are understanding rhythm based off of the mother's walking, which is very fascinating. And then of course the heartbeat is another rhythm. So we gravitate towards rhythmic things. This is also why in Parkinson's you will see a freezing gait, but then as soon as someone with Parkinson's starts to dance, they never freeze. So if you've ever heard that, that is part of the auditory rhythm side of the nervous system, which is quite fascinating. The joint is going to represent proprioception. So that's the joint capsule. So that's stimulating. That's like why wobbly surfaces are very stimulating to the brain, because you're stimulating proprioceptors and the joints. What I will have patients do, again, love the vibration, but I will have them take, I've also worked with babies with neurological injuries. So for babies, I'll do this a lot, but you can get little baby massagers that vibrate, and you can do it around the joint. So you're essentially just stimulating the joint. Every joint is packed with thousands and thousands and thousands of nerves. So if you're trying to wake up joints for joint stability, for balance, you can essentially create a vibratory stimulus around every joint, and you're stimulating the joint capsule. So do it to the knees, do it to the ankles, right? So that's a very powerful stimulus. Kinesiology tape is huge, and that's where kind of braces come in also. And then the feet we spoke about, that's the mechanoception. So we have these 4 systems that are essentially coming together to help maintain stability. And this is called multisensory processing. So the more sensory systems that you stimulate at once, the more that the brain is going to be activated. And at the end of the day, the name of the game is trying to really wake up the brain so that it can repair and create new synapses for motor control. So we're waking up the brain. Okay, so multisensory processing. And what that essentially means is that you have these four systems. How can you incorporate stimulation to the four systems to enhance overall brain stimulation? I call this sensory stacking. Okay, so you can stack and bring in multiple stimulation to then further upregulate. Okay, I will give you a quick example. So let's say I'm holding the neural ball. So the neural ball is textured and it is in my hand, which is full of touch nerves. So that is one stimuli to my brain. But if I look at my hand while it is being stimulated, not only do I feel the texture, but I see my hand as it is feeling it, which means I am stacking visual stimulation with tactile stimulation. I'm actually stimulating the visual cortex in the brain while I'm stimulating what's called the somatosensory cortex in the brain. So I'm getting this dual cortex stimulation, which is very powerful. Okay, that's an example of a stack. Another example of a stack could be, let's say I put kinesiology tape around my ankle to stimulate the capsule, and then I go on to a wobble board or the kinesis board. it's also stimulated. So I'm trying to bring in, so the kinesis board is a wobble board that has the Naboso texture on top, right? So we have the texture and then we have the wobble. So I'm getting texture to the bottom of the foot, wobble, and then there's kinesiology tape around my ankle. So essentially I'm stacking tactile with proprioceptive, right? Just want to kind of get that brain as stimulated as I can. To me, some of the most underutilized areas of the body to be stimulated is the hands. So when I have a patient do a lot of their programming, I will try to get the hands involved as much as possible. So let's say if we are doing a single leg balance on the kinesis board, I would want in the hands the sensory sticks. And those are right here, you can see the sensory sticks. They're holding the sensory sticks. If you don't have the sensory sticks, you can hold the neural ball, just split it into two pieces and hold, I dropped the little ball, hold the two pieces in your hand like this, right? That I'm doing it. If you don't have that, hold some 2-pound weights, right? Something, right? Find something. Just put something in your hands while you're doing it. Okay. So here's a couple other examples of sensory stacking of what you could do. You're going to be barefoot on a Naboso mat. So we're getting that tactile, we're barefoot. Maybe if you have shoes on, we're going to put the insoles into the shoes, add some kinesiology tape, as I had said, put some compression apparel on. Maybe you have the Naboso socks while you're on the wobble board. You're holding, you have wrist weights on, and you're doing something, sort of trying to stack, right? We are on the kinesis board with the texture and the wobble and the kinesiology tape, and you're holding the sensory sticks, and you're looking at yourself in a mirror. So now you're looking at yourself holding the weight. You're looking at yourself feeling the texture under the feet, right? So we're trying to connect. I am a big fan of mirrors for the visual stacking that it creates. When someone has a disruption in body schema and you're not in a mirror, it's hard for them to connect because the brain doesn't have the story of where it is. So strategically, how do we use mirrors? And then how do we take that mirror perception and we shift it for them to actually feel as the arm is moving in space? So right as you, if let's say we're just doing a lateral raise, this is a lateral raise, and every time we lift our arms, we're in the mirror and we see our arms moving, right? And I'm really feeling and connecting to my arms moving. If I turn away from the mirror, can I try to carry that same mental picture of my arm moving into a lateral raise? Okay. So we are looking at the foot every time it steps onto the vibration platform, right? You're looking, you see it, you feel it. You're looking at the hand holding the Naboso, the ball, the vibration ball, whatever it is. Okay. Oops, sorry. Let's drop that up real quick. Sorry. So you're trying to stack it. Okay. Now, sometimes when I teach about this concept of sensory stacking, a lot of people will feel that it's kind of like rubbing your stomach and patting your head, which I actually can't do, that you're doing that, right? And that's not what I want it to seem. I want it to be just remember the four systems. If you take your shoes off and you do an exercise, if you don't want your shoes off, can you put the Naboso insole in the shoe so you get that stimulation, and then you have wrist weights on, you have your compression apparel, you're looking in a mirror while you're doing it, and then so we're trying to, and then there's music, right? And then you're moving to the beat of the music. So now we got something for the ears. That's the music and the auditory. We have something visual. We're looking in the mirror. We have something proprioceptive. We have the kinesiology tape on our ankle. And we have something tactile. There's something in our hands, right? So we're just trying to think about every exercise and how do you just sensorially enhance it a little bit more than where it is right now. Okay. And that's just very, very important, especially when people have a neurological deficit, which means they might have neuropathy. They can't feel their feet, or something like that.
I don't think I even talked about this, but to piggyback off of what Dr. Emily was saying, they have virtual reality now that I've been reading a lot more of. We don't have virtual reality at my practice or at my house. We don't have any of those, but Logan did use virtual reality when he did vision therapy, and it really did seem to help. And now they have different, like, research and different exercises that you can do to help with neurological conditions and balance and gait and reactive strategies and stuff like that. So I'm going to keep looking into that, but I think that that's something that's really fascinating too, because then it's exactly what she was talking about, sensory stacking. So we're using multiple systems, our vision, you're maybe hearing something at the same time, and you're obviously trying to feel, your joints in space, your feet, all of those different things. So which is fascinating. So that's kind of the direction we're going. Case example here would be my husband, post-stroke patient with foot drop, poor push off, poor balance. With that, we can assume that we have, poor hip extension strength, poor hamstring strength, which is also hip extensor, and poor like hip abduction strength for, poor hip stability, all those different things, probably poor anterior tib strength, peroneal strength, hip flexor strength, maybe core activation from the front, and rotation. So some stuff that we do in the office, or I have him do on his own as well, we do vibration. So I think that there's so many different ideas, and there's just so many different ways you can, improve that sensory input, and different things you can try, that it's almost like, how do you even know what to do? Like you have all these things at your grasp, but how do you know what to do, and how long do you know to try it for before switching to something else? And so I always tell people, like, let's give it, at least a few weeks. When we do like different training blocks from like a strength perspective, we let things usually like go like 4 to 6 weeks, because sometimes it just takes a little bit of time for your body to learn and to be able to adapt. And so once you actually like tap into that sensation, you're maybe not even really noticing the improvements for weeks down the road. But so you just got to give it more time. And then if that's not working, then obviously switch to something else. And if that keeps working, then you can stick with it. There's no guideline on like how long you need to do one thing before switching to something else. So you just got to find what works. So we do a lot of vibration. It seems to calm his nervous system down. There's people that have more spasticity and more like high tone presentations. And then there's people that have more like low tone and like the atrophy and those sort of presentations. So obviously vibration works for him. With that, we do like some functional electrical stimulation. So that's using his Bioness or the electrical stimulation pads to do some marching. So we're working on that hip flexor, a little bit of that quad, that proximal rectum, and anterior tib. So just having him march in place, sometimes on the vibration plate, trying to integrate multiple systems and stack more modalities on top of each other. Then we go into some Captain Morgan lifts, like I was showing you guys with the stability ball on the wall, trying to work on that lateral hip strength, a little bit of that balance integration, and using his core. And then going into, usually we do some more like strength training stuff after all this, but we do pole walking first. So anytime that you can ramp up the nervous system and do things that are a little bit like higher intensity. So high intensity gait training has a ton of research. And they talk about this all the time in like neuro rehab. And so just, it doesn't have to be gait training. I just think about it like high intensity training. So if you get your heart rate into certain zones, then you can help to drive up neural drive and neural stimulus. So we have that central nervous system component, and we want our nervous system to be turned on appropriately. We don't want it to be like, obviously, not turn on enough or overly turned on. But if you calm it down with the vibration and then you start to reintegrate it back into some of this stuff, then it should be turned on just enough to be able to get more out of the things that you do after this. So we do the pole walking with a visual or cognitive task, and that could be like, count backwards from 100 by threes, or name every president that you know, whatever it is, just to get your mind off the task at hand and try to make it a little bit more natural and less like you're thinking about every step that you're taking, because that's obviously supposed to be something that's more natural too, that we just know how to do. And so that's kind of like what we would do for our intervention to work on just like the gait component. And then we usually do some like strength stuff. And then the outcome would be he has obviously improved step length from this to work on some of those longer strides, especially with the poles. Balance it has improved, working on just like the Captain Morgan, more time under tension. I think I talked about it before, like more reps is better for people that have a neurological injury, because sometimes like the first few reps, they're not feeling it. They have no idea kind of what their body is doing in space. So it takes a while for them to tap in and be like, oh, I kind of feel what I'm getting out of it. And it's like that 8th, 9th, 10th rep, they're like finally getting it. So I don't want to stop there. I want to go until fatigue, not failure, but fatigue for whatever they're doing. So obviously that's going to be helping confidence as well, because now if we have better balance, then we feel comfortable, taking a shower with our eyes closed, right? Without having to worry about like, what if I slip? Or is my wife home, or any of those different like factors at play. And obviously that reduces your risk of falling, and then it gives you more independence and your life back, which is huge. So some key takeaways, the foot is just critical for any neurological impairment, assuming that you have something that's going on at the foot. We think that, every time that you have, even a different neurological injury that maybe is more like upper body focused, you still, like, everything starts from the ground. So our foot is the first thing that goes in contact with the ground. And the better we can get everything up the chain to work together and synchrony, the better everything is going to be too. And it's going to help to just give you back that aspect of your life. So targeted sensory and motor retraining, it's really important to improve balance, confidence, coordination. And then like I always think about doing this like small, consistent routines. So a 5-minute routine, a 3-minute routine, movement snacks. That's what I like to call like things that you do throughout your day, just to like keep like fitting them in wherever you can. I'm a big believer in habit stacking. So if you can, while you're brushing your teeth, do your little routine, then you know you're going to have a time to be able to fit this into your life versus having to carve out time or seeing where it fits. Usually people aren't consistent with that. So I always like to find something that works for them and then like fit it in their life. But doing things consistently creates really big changes quickly too. When my husband was like given exercises by his occupational therapist, she gave him things to do while he was like working on the computer. And so he was like, whatever he was typing, and then every few minutes he would do whatever he needed to do for his hand. Doing that over and over has caused him to get a lot of progress in a short time, and like progress that they never expected him to get. And same thing goes for the foot, but we first have to get the foot out of the shoe and in contact with the ground to be able to get the most out of our exercises. So sitting down, watching TV, it's a great time to do this, but these little things have a big impact in our day-to-day movement. And I believe fully in a multidisciplinary approach. So obviously Dr. Emily is a podiatrist and, I'm a physical therapist. She knows a ton of amazing information about the foot. Amazing, way more information about the foot than I will ever know. So working together and kind of tag teaming some of these strategies is huge because I can't possibly know everything and she can't possibly know everything, but together we can really create a system and an approach that works for each patient. So a little sample of like a routine that I would have someone do wherever it kind of fits in, rolling out their foot, with the ball, just something for sensory. So something for sensory, and then working on walking, getting your heart rate up, doing something repetitively. I just love walking because it's just a lot of like repetition in a short period of time. So going for a walk around the block, walking up and down the hallway, whatever you need to do, walking, if you have a treadmill, something like that. But it also could be like riding a bike, getting on an elliptical, going up and down stairs, whatever it is, just something with repetition. He likes to use his BioNest because it's on his leg already, but you could use some electrical stimulation or just like tapping and trying to get things to wake up a little bit more. Mobility, so I like to do ankle circles, which is like they're standing up for this one. It's super, super easy. If you can see me. So you're like here, like this. So just kind of getting your foot and in all different directions, kind of to wake up and mobilize. I like it too because we're getting that proprioceptive input and that joint awareness in different ranges of motion, as well as different planes of movement, which our foot works in three different ways. So it's really important to do toe curls and lifts, obviously being barefoot, curling the toes, lifting the toes. And then I already showed you guys the heel to toe push off, trying to like take a step forward, almost like tandem step, and then trying to get that push off, that full range of motion, mobility of the ankle into plantar flexion. Strength, just some like put a band, one of these guys around your feet. You can put your hand on the wall if your balance is an issue. Just some marches. You can also do this sitting down, and that's where Logan and I started with this to work on a little bit of that ankle strength and hip strength and a little bit of balance too with that. Calf raises, just calf raises using the wall. Squats to lateral band walk. Doesn't have to be with anything fancy. No, you don't even need any weight for this like quick routine. This band goes around like your feet or like the lower part of the leg to make it a little bit more challenging for the hip abductors. So squat, take a step. Now we're moving in a different plane of motion and you're kind of integrating several different things into one exercise. I love bang for my buck. If I'm going to only do 4 exercises each day, let's make sure they're worthwhile. And then butt kickers, so you're standing and kicking your butt like this. And you can do all this holding onto the wall. Just once again, that's that reintegration of that hamstring and also just to stretch out the quads to break through some synergy and use momentum, which helps with movement. And then just doing some arm swings with rocking. Should just probably stand up, but like this, that's that push off too. Now we're integrating everything together. So now we're getting that cross body rotational pattern. Just a few of those on each side. Split stance to row. So now if you have like a band that's hooked to maybe like a doorway or something, you can just kind of like do this. And now we're doing that cross body rotation too. Once again, it's just to integrate more systems together, more muscles together to kind of use the things that we do need to use throughout normal movement. And then squats with 1 foot elevated. This is one of my favorite exercises for anyone that has like one-sided weakness or anything that's like more so on one side. And the squats are, let's see, I had a picture earlier, but obviously if this is my weaker side, this is going to force me, since this side is elevated, to shift over to the side. So it doesn't have to be like really like low and like all the way to the ground, but this is great. And then you can still switch it to the other side and then have that uneven surface to work on that balance component. Obviously, you can integrate like the music, metronome, anything into these too, visual stuff, cognitive drills, whatever to make it more fancy. But I think simple is best. So simple is what gets people the consistency factor. And so they're able to actually integrate this into their life a lot easier. And then they see a lot of benefit from that. Okay, I think that's it, at least from my part.
For your part. So if you want to wrap up, then I'm going to wrap up with something.
Yeah, if you guys have any questions, I think that there's a couple questions coming through, but if you have any questions about like the rehab aspect or things that you want to know about that, or anything about rehab stuff or exercises, I did a post recently on my Instagram page about foot drop exercises to help with that. That's usually a big problem in the neurological injury population. So if you guys want to check that out too, it has a lot of good ideas and it shows the functional electrical stimulation and how I use different systems to help with some of that sensory stacking.
Great. Thank you, Stacy. So just make sure you scan that, follow her, email her, follow her on Instagram.
Yeah.
And then as I'm wrapping up my part, if you have a question for either Dr. Stacy or me, you may type that in right now. And then we obviously spoke a lot about Naboso, so do check out Naboso at naboso.com if you would like. I do want to wrap up my part with just a quick story around the power of foot stimulation. So I had a patient who had a C5, C6 spinal cord injury, and she went in for neck surgery for a spondylolisthesis where the vertebra had shifted forward. And during the surgery, the surgeon nicked the spinal cord. So she woke up with what was supposed to be a pretty straightforward surgery, and she woke up paralyzed. Couldn't imagine. And so she went from bed bound to wheelchair, and the entire time of this had happened 2 years ago. And for almost that entire 2 years, she was kind of advised, or it was just shaped in her neuro rehab, that she was kind of protecting and bubbling her feet like they were in super comfortable socks. And obviously she couldn't feel her feet. She had spinal cord injury down. And so they were always in super fluffy socks, shoes, or like slipper, kind of just, again, in this like pillow to bubble. And 2 months ago, from when I had seen her, she then had switched to this company called SciFit, which is a spinal cord rehab company. They're across the US, so SciFit. They specialize in spinal cord injuries. And we work with them at Naboso. And it was the first time in this 2 years since her spinal cord injury that someone told her about stimulating her feet. And she took off the fluffy socks, and for the first time, she experienced Naboso. And she said that she had this like electrical sensation in her feet. And she would get these kind of like zings up her legs, and just this like powerful shift that she had noticed. And she then started incorporating foot stimulation, started incorporating Naboso. And then she eventually came to Arizona and saw me as a patient for me to look at her protocol and say, this is how you can dial up a neurosensory perspective to your program of what you're doing. But when I saw her 2 months after stimulating for her feet for the first time since her spinal cord injury 2 years prior, she is now with a walker. And when I was assessing her, she had so much strength. Like she got up on the exam table. Like I was just like, and she was like, my dream is to walk again, like without a walker. And I was like, oh my God, this woman. And she was like, no one told me to stimulate my feet. No one had me. All of these spinal cord rehab specialists from the time of the injury, my feet were in fluffy socks and no one stimulated it. And so to me, that's like such a powerful example of what Dr. Stacy and I are speaking about is you have to feel your ground, and it is the ground, and it is innate in the shaping of the human nervous system, is that our nervous system was designed to feel the ground. Every motor milestone from the moment we are born is based off of us creating a relationship with gravity to ultimately be standing on our feet. So I cannot emphasize this enough, like underline, highlight, circle, everything that we're talking about. But what I just want to share as we wrap up is a couple additional things that I gave this patient who's going through the spinal cord injury. Is I gave her a lot of visualization, and I'm a huge believer in visualization, and there's a lot of research behind if you visualize yourself doing something, you still get motor neuron activation. So let's say I'll give an example of in a non-neurological space where I could use it with a patient is, let's say we're in like a push-up position and you want to start to kind of do something like this, right? So you're going to push up and then you're going to tap, but you're hesitant to lift one arm and then do this single-handed push-up plank position. If you just hold here and your eyes are shut in that push-up position and you visualize and you see yourself doing the shoulder tap, you just see yourself, you will actually get a motor activation, the motor neurons that are required to hold the weight on one arm and tap the shoulder are actually being lit up. So it's very, very fascinating, the power of visualization. So what I had her do is I said, I want you to visualize, and you are going to visualize one of her big things that she wanted to like get out of bed and walk to the bathroom. So it's like, you're going to be lying in bed and you're visualizing this. You're not doing it. Obviously, you're just visualizing. And I was like, I want you to sit up and see yourself standing out of the bed and you're walking to the bathroom, and then go back. You're lying in bed, sit up and strongly stand up out of the bed and walk to the bathroom. And you're doing this again. And I want you to do it over and over and over every single day. You're going to do this. So I'm a huge, huge, huge believer in neurological injuries of the power of visualization. Visualization could also be as you are doing a movement, let's say you're doing that lateral raise again. As you're doing the lateral raise, I need you to see your arm moving as you're moving it. So you're strengthening that power of the mind-body visualization. So that is one that I gave her. And then the dry brushing one is one very, very important one that I gave her. And then the neuro stick. And I told her husband, I said, before she does her morning stretches, she has kind of this little stretch routine. I was like, I need you with either the dry brush or the neuro stick. I need you to do every inch of her body and then let her do that visualization. So those were some really, really important things. Of course, I had her take your shoes off or get in the Naboso socks. I told her about stimulating the hands and everything. Obviously, the breath. We could have a whole nother webinar on the pelvic floor. And no one 2 years since her spinal cord injury spoke to her about diaphragmatic breathing. And your diaphragm is in this beautiful harmony with your pelvic floor, which is in harmony with your feet. And that's how we maintain posture in gravity. That's how we stand in gravity, is through our diaphragm, our pelvic floor, and our feet. So I had her start doing diaphragmatic breath work. I had her start to connect to her pelvic floor through these very simple kind of clock exercises and through her diaphragmatic breathing. And as she extends her exhale, I wanted her to really connect to her pelvic floor. Because again, with a lot of neurological injuries, there's a lot of incontinence and urological issues that come with it as well. And so the pelvic floor is not just about like incontinence. The pelvic floor is how we actually stand in gravity. So that was another component that I gave her, was to connect to her diaphragm, connect to her breath, and then to connect to her pelvic floor. And I thought that that was a very important, powerful component of this. So I had just seen her maybe like 6 weeks ago, and I'll be seeing her again in a few months for another phase of her programming. So as we wrap up, if you have any questions, please type those in. Here's my information. You had Dr. Stacy's on the other one. Follow me on Instagram, follow my website. I actually did not include, I don't know why, this also on the other webinar I didn't include it, but my practice where I see patients virtually. Again, most of my patients are virtual. It's actually just my name. So dremilysplickle.com is my website. So if you want to see me as a patient. So Stacy, I'm going to pop in there and see if there's any questions for you or me.
I can answer the third one.
Which one?
About spasticity.
Okay.
So the question is, what are the tips for healing spasticity? Spasticity with that eccentric muscle contraction of the calf, or like the clonus thing that a lot of people get when they like stand up or, kind of put any pressure on the foot. So obviously there's different ways you can work through spasticity. Botox is always an option that a lot of doctors like to try, to like shut down that muscle, and then to strengthen the opposing muscle, or give the other opposing muscle time to be able to get stronger, and also a time to lengthen the spastic muscle too. So like for the calf, for example, obviously like lengthening the calf muscle itself, because what happens is our reflexes try to kick in too early, which causes that spasticity. So every time that it tries to lengthen, it doesn't want to lengthen. And so it just goes back into contraction. So finding like overloading the lengthening portion and then sustaining that stretch is huge for spasticity. There's different splints that people will use, different like devices, like you can wear it while you're sleeping at night. Obviously, that's why some of those rigid AFOs are really helpful for people too, because it does keep you in a certain position to be able to keep you in this like neutral foot position posture. And that obviously is helpful for clonus or some of that spasticity, but trying different things like that, and then like strengthening the opposing muscle groups, and then learning how to strengthen through the larger range of motion. So like eccentrically controlling like a calf raise off like a step is really huge too with the weight, because you can overload the stretch, which will shut down the reflexive cycle, hold that position, and then go into a calf raise. So anything that you do, if you do it slower, it tends to help. So then you don't have that reflexive spastic motion happening. So those are just some things that I've seen that are really, really helpful. But Botox is one of the ones that they're really, really pushing right now. But I think Botox without kind of taking advantage of that time and working through and strengthening different areas is a waste of time. So you got to make sure that you do exercises while your Botox is kind of like sitting in there too, to get the most out of it.
Yeah, no, that's a great point. I send a lot of patients to get Botox for spasticity, whether it's a central nervous system neurological, or I see a lot of dystonias and other kind of intermittent spasticities or hypertonicity. And that is the biggest thing. As I say, Botox gives you the opportunity to then focus on reestablishing the motor pattern that it's essentially inhibiting, right? It just keeps getting in the way of progress. You can't just do Botox and then not do anything else, right? That's a really, really great point. There was a question on vibration, and What I want to share around vibration is that there's an ideal frequency based off of what you're trying to achieve. A lot of the vibration platforms vibrate between a 35 and 55. So it's kind of like the sweet spot for like a plate. And then there's low and high amplitude. So those, I like lower frequency just because the foot and the ankle contract at or respond to lower frequency vibrations. A lot of vibration rollers and things like that vibrate at like into the hundreds. So it's a very different response. Again, lower is typically what I try to have for people to respond to. So if you can do a lower, that fascia hydrator that I mentioned, it actually has 3 settings. It has 40, 90, and then I think 125. When I have patients use it, I like the less than 100 frequency. We'll see if there's any other questions. Some people were asking about the recording. Yes, everyone will get that, and the presentation notes as well. Perfect. If there are no other questions, then I want to thank everybody. I'll let Dr. Stacy say her last words, but thank you so much, and we hope to see you on another webinar.
Yeah, thanks everyone. Thanks for tuning in. Obviously, there's a lot of information here, so everyone's going to get the recording, like Emily said, after, so you guys can go back through that, watch it. If you have any questions, you can message us or get in touch with us. We both take patients, we work with people, and if you're having these issues, we would love to help you in any way we can.
Wonderful. Thank you, everyone. Have a good day.